pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing baby, child and young person education to primary care clinicians. I'm delighted today to be joined by Dan Magnus, who is a consultant in Paediatric Emergency Medicine at Bristol Royal Hospital for Children. Welcome, Dan.
Thanks, Ruth. Very nice to be with you.
Thanks for joining us today. We are going to go through the topical topics of measles and whooping cough, chatting about how do you diagnose them, how do you manage them, and then more generally about how do we assess the sick child using Dan's expertise from A&E Medicine. So, using two cases to ground our discussion, the first one. 3-year-old Max is brought to his GP with rhinorrhea and a non-productive cough for several days, fever for 3 days, and today developed a rash on his face. He's got several contacts with coughs and colds. Max is part of a traveller community, and his vaccination records are incomplete. On examination, he looks flushed and lethargic in mum's arms, but has moist mucous membranes. He's got a temperature of 38.8, a heart rate of 166, respiratory rate 44, SATs 95% on air, and a cap refill of 3 seconds. He's got a blanching erythematous maculopapular rash on the face, neck, and upper chest. Heart sounds are normal, but he's got some intercostal and subcostal recession and reduced air entry at the base of his left lung. He's got a pink pharynx, but otherwise ENT exam is unremarkable. There's no photophobia or apparent neck stiffness. Dan, what do you think of this? Is there anything else that you'd want the primary care clinician to include in their history or their exam?
It's a good question, Ruth, and it's a good case which I'm sure lots of the people listening will be familiar with, actually. The child presenting with fever and rash and generally unwell is a situation which in primary care and in the emergency department in which I work is a very common situation. Of course, in this podcast, we know that we're describing and probably going to be talking about a case of measles, but we only know that. And of course, most of the time we're confronted with a child where it's on a differential, and we'll talk about that, I'm sure. In particular, though, with the measles situation being as it is across the UK, a vaccination history is really important, though it doesn't rule out measles by any chance. And then, of course, in the era of pandemics, asking questions specifically about measles contacts, or in a more general sense, any infectious contacts, is a really important part of the history. The other thing, just in a general sense, is that kind of feeling that we've all got when we're confronted by a case like this about whether we're looking at a really, really unwell child or not. Because important as the differential is, important as the diagnosis is, and this is spoken, I'm afraid, like a true emergency paediatrician, nothing will ever completely trump that A to E approach for assessing the potentially very unwell child. And so if, on that initial assessment, there are really, really concerning warning signs that this is a child with a life-threatening illness, then irrespective of whether we think this is measles or not, though that is very important, this is going to be a child that may need referral and onward treatments and investigations.
And would you mind talking us through that A to E a little bit more? What do you mean by that?
Yeah, so most of the people listening, I suspect, will be very familiar with this, but right from undergraduate level all the way through to the kind of thing that I do myself every day, including in the shift that I've just finished today in the emergency department. Are there signs of airway compromise? Is the effort or the efficacy of breathing a real concern with tachypnea or oxygen requirement or lots of increased work of breathing? Are there signs of circulatory failure, delayed capillary refill time, low blood pressure if we're measuring that, which ideally we should be, but we acknowledge is a challenge in children, or signs of delayed or poor perfusion? A disability assessment, is this a child with a reduced level of consciousness or who's particularly irritable or particularly drowsy? A blood sugar, if it's possible to do that, is always an important thing. And then finally, an exposure. What's the temperature? Is there a rash? Are there any other things about the overall well-being of the child that would change what we do? So I think that assessment is really important. And in the case that you've described with little 3-year-old Max, some not huge red flags, but some things that would just make us feel a bit uneasy. The high temperature by itself is not a big problem, but the heart rate is a little bit fast. The breathing rate is a little bit fast. The saturations are 95%, which is okay, but are not 100. And the capillary refill time of 3 seconds may be a feature of temperature and may not reflect a child with shock. But altogether, and with the history, when you're actually seeing the child in real life, those things together might just cause you enough concern, at least to seek some advice and guidance if you're not sure.
Brilliant, thank you. You said that this is quite a typical child where there would be a number of differentials. Do you mind chatting us through some of those differentials? What would be the possibilities if you saw a case like this?
Yeah, this is a really important thing, and actually it's an approach I use very often with parents when I'm seeing their febrile child, which is to talk about quite explicitly with parents actually, who by and large are very well informed about the things that it could be and the things that really worry us. Could this be sepsis? Could this be pneumonia? Could this be scarlet fever? Could it be in a child with a very high fever and a strange-looking rash? Could it be something like Kawasaki disease? Slightly unusual as that is, but if we're not thinking about those more serious bacterial infections and those more serious systemic illnesses, we'll miss them. And most of the time, children presenting with fever and rash, as you know all too well, Ruth, in primary care, do not have very serious infections, thankfully. But I think it is important to be explaining that to parents, documenting really clearly red flags or lack of those, and then making sure that we feel confident saying to parents, and this is the language I use, look, there are no signs of really serious infection here at the moment. I'm very comfortable that it's safe for you to go home because of the vital signs and the assessment. But also we need to see what happens in the next 24 to 48 hours. And if things get lots worse or you're much more worried about other red flag signs, then you must come back and see us. In this case, of course, there are some features that do make us worry about more serious illness, and certainly measles with high fever and some of the features that we've described would be on our differential, along with things that we haven't put in this case specifically, the very miserable child with conjunctivitis, the child with a very measles-like rash, which is always a bit of a funny term, but does have quite a distinctive rash, a rash that typically starts on the face and behind the ears. And then those kind of really key features that are not always present, but that your listeners will be very familiar with, like the presence of Koplik spots, for example.
And there's no mention here that the clinician has specifically looked for Koplik spots. So what would you want them to be looking for? What do Koplik spots look like?
Good question. They're really well described in our textbooks and in the literature. They're sort of small, bluey white lesions, normally about 2 to 3 millimeters in diameter. And they just sit at the base of the buccal mucosa, so just at the base of the gums, normally back by the molars, that tend to appear around the time of the rash. When they're there and you'll know it, and that definitely makes you think measles, but they by no means guaranteed to be present. So the absence of Koplik spots does not mean that you don't have measles. The cases of measles I've seen in the last 12 months, for example, I've not seen Koplik spots, and I've seen a reasonable number of cases of measles. So Koplik spots are classic, but it's really important to be really thinking about miserable child, distinctive maculopapular rash that is red and blotchy, that's typically not itchy and tends to start around the face and neck and spread downwards.
Would that fit with this case? Would you have measles on your differential list here?
Yeah, I think I probably would. Absolutely. Though it may be some other viral illness, one of the key things is deciding how unwell is the child. Could it be another virus? There are childhood viral exanthems, things like roseola, parvovirus, and other non-specific viruses that we don't diagnose but that fit a febrile viral picture. Those are all possibilities, but the key thing is that particularly in the child where there are enough features of measles to make you think it, that is a very serious public health consideration that needs careful thinking about testing and notification.
Absolutely, and we will speak about that a little bit more. Is there a particular pattern that you see with measles? Is there a particular order of any of those symptoms that you've mentioned? And how strictly do you find that measles cases stick to the typical pattern?
Yeah, that's a good question. I'm always wary of that because rarely in life do things stick to what is described in the textbooks. But certainly what is described is illness first, cough and runny nose for a few days, followed by rash. And around that time, the onset of fever. So it's not uncommon to have what looks like a normal cough, cold virus initially that then goes on to develop rash and fever. The symptoms typically peak on the first day of the rash. So everything comes in full technicolor at the time that the rash emerges. We've talked about the distribution of the rash and how it spreads. The rash generally lasts for between 3 and 7 days and will gradually fade. But there are some things that for people who have seen measles will resonate, which is, the really miserable child. Children with measles are pretty poorly normally. I don't necessarily mean that they all need to go to hospital. I just mean you tend to be quite miserable with measles. So that combination of cough, runny nose, fever, rash, conjunctivitis often but not always, Koplik spots often but not always, that really starts to fit the picture. Of course, the difficulty is that also sounds a lot like lots of the other viral illnesses
It does.
that we see.
Yeah. And are there any complications that we see with measles?
Yeah, it's an important question. And I think particularly from a primary care perspective, this is the real heart of the issue, actually, because measles is an incredibly infectious disease. And we want to be doing everything we can to keep children with measles away from the hospital environment. And most GPs and advanced care practitioners are very conscious of that, want to keep measles away from hospitals. And so the real question is, are you seeing a child with the complications that would make us worry? And those complications are things like pneumonia and pneumonitis. So children who've got a measles picture, but who also have got signs of respiratory distress or signs of pneumonia when you're examining their respiratory system. Signs of sepsis or more serious infection that can coexist with measles. Those are important things to look for. And then encephalitis or neurological involvement can be, though it is reasonably rare, those are things to really look for. Otitis media, diarrhea. Finally, but not least, SSPE, the subacute sclerosing panencephalitis, that children who have had measles can present with later on. Now, you're not going to see that in the acute phase, but those kind of complications, of course, are very serious and need to be on our radar. In summary, and for the average day in primary care, a child with measles, the things I would be really worried about would be signs of pneumonia or respiratory compromise and signs of encephalitis, though there are other complications, as I've mentioned.
Thank you. So how would you want the primary care clinician to manage Max?
If there are obvious and concerning danger signs on that initial A2E assessment or features that really merit urgent and emergency investigations and treatment today, then like any other child with a nasty acute infectious presentation with red flags, referring them to the emergency department. If you are, in this case, querying, for example, a nasty pneumonia in a child that needs oxygen, for example, because of measles, I think that would be a really, really important reason to make sure we're phoning ahead so that we can talk about that, because the R0 number for measles, just to remind you, is much, much higher than most of the viruses. Off the top of my head, the R0 is something like 15, which means that in a susceptible population, one child with measles will pass that on to 15 other children. That number is about 5 for COVID. So it really is an infectious disease that we want to keep away from waiting rooms and from immunocompromised children and from pregnant women. And that's a very, very important public health consideration. But if the child is poorly enough, then they need to be referred and we need to see them. If the child in primary care is unwell but not in need of emergency treatment or other emergency investigations, then of course, unfortunately, for the measles itself, there's no treatment, but treating a pneumonia, for example, that doesn't need hospital admission with oral antibiotics would be a totally reasonable thing to do. Same for an otitis media, for example. The more important thing in some ways, actually, on a case-by-case basis, will be the public health considerations in terms of the notification and testing that needs to be undertaken.
Can you tell us a bit more about that? So if we think it might be measles, is there anything we ought to be doing in primary care?
Yeah, this is important. Under ones, immunocompromised children and people who are pregnant, those contacts and that kind of contact tracing is important to prevent additional spread of measles and complications. In the primary care environment, thinking about, though I appreciate this is often difficult in practice, but infection control is important. So you'd want to avoid these children actually sitting in your waiting room. As the clinician seeing the child yourself, if there's any concern about measles, ideally you really want to be wearing PPE, including an FFP3 mask. And then the important thing to contact the health protection team, at the very least, to get their advice and guidance. Really, the important thing for suspected measles cases is infection control, isolating where possible, and then doing testing to confirm those cases. My understanding is that the health protection team locally will actually send families oral fluid sample kits to test for measles, IgM or IgG. But I think it is also possible, and I don't know what you're doing in your practice, Ruth, but I think a lot of GP surgeries are also doing some of the swabbing in practice. But I don't think clinicians have to do that. The health protection team will help families do that. But certainly mouth and throat swabs for PCR can also be used, and I think many GPs are doing that already.
We certainly do that. I think the only time that we really rely on the health protection team is if we're out of swabs. But otherwise, we will do that. And actually, in our practice, our standard protocol is to see these patients in the car park, so with the children still in the cars, so that they're not coming in, they're not bringing that in, because it can be airborne for up to 2 hours, then otherwise means that room can't be used
Correct.
to see other patients for another 2 hours
Correct.
afterwards.
No, it's a really important consideration, and I think is why in secondary or tertiary care we sometimes get a little bit precious about that. If a child with measles comes into our waiting room and there are 60 children plus a parent each, so 120 people in there, that's a pretty serious issue in terms of infection control. As long as we're all cognizant of that and focused on the implications, I suspect everyone will be doing the right things.
Yeah, and in terms of contacting the Health Protection Agency, so we've got a standard form that we send off for it, but actually with the case of measles, if your R number is 15 to 20, that's pretty phenomenal. So
yeah,
it's worth picking up the phone and just calling them, particularly if you've got any worries about vulnerable contacts.
Yeah, absolutely. And we are seeing sporadic and continued outbreaks of measles, and it's a slightly sad reflection in some ways of where we are with some of these infectious diseases. Thinking about the importance of vulnerable contacts, the importance of notification and testing, the importance of really extolling the virtues of vaccines, because it's never too late to have the MMR. These are very effective vaccines that certainly reduce cases of measles, certainly reduce spread of measles, and at the very least reduce clinically significant cases of measles. Whilst mild cases of measles are far from ideal, what we really want to see, of course, is avoiding severe cases of measles with significant morbidity and significant mortality, particularly in those vulnerable groups that I've mentioned.
Absolutely. So do you know how effective the measles vaccine is, the MMR?
I do. I mean, Ruth, not least because I was making sure I did a little bit of preparation for this podcast. So, yes. So the vaccine efficacy is quoted as 95% after one dose of MMR and 96% or even above that after 2 doses. So it's pretty effective. And as I say, certainly reduces severe or clinically very apparent measles. Of course, the really important things, as I say, are preventing severe cases, preventing spread, and of course, herd immunity. When herd immunity drops below about 90%, when we start to really see spread, vaccine uptake is variable and is a real issue for us in the modern era.
Fantastic. Thank you. That's very helpful. So moving on to our second case. Parents present to primary care with 6-year-old Ava, who's had 10 days of a cough, coryza, sore throat and a slightly reduced appetite. But over the last 2 days, parents have been concerned by several violent coughing bouts per day, often at night, and that often end with vomiting. Mum's worried because there's been reports of high rates of whooping cough on the news, but she says she's not really sure if that's what Ava's got because she hasn't been making a whoop noise. There are no known contacts, and she thinks she's up to date with her vaccines. On examination, Ava is quite upset and resistant to the examination, but she's alert, she's pink and well perfused with moist mucous membranes. Her temperature's 37.7, with a heart rate of 112, respiratory rate of 30, and SATs of 98% on air. She's got 4 petechiae on the face, but no other rash or signs of meningism. Her heart sounds are normal. She has slight subcostal recession, but other than that, there's no signs of respiratory distress, and her chest is clear. Apart from a pink pharynx and some scanty cervical lymphadenopathy, her ENT examination is also normal. So what do you think might be going on with Ava? What would be the potential differentials here?
Unfortunately, quite a common presentation in some ways. We're all familiar, I think, with the fact that respiratory presentations in children of this age are incredibly common. Again, important and thorough A to E systematic approach to assessing the child is really important. And assuming the main concern here is around coughing and breathing and the respiratory system, thinking about common things first is important. So viral lower respiratory tract infections are common and can be important, particularly if there is a wheezy component to it and a child that's got increased work of breathing or an oxygen requirement. Thinking about common similar respiratory infections in very small children and babies like bronchiolitis. Though, of course, we've got exciting things on the horizon with the new bronchiolitis vaccine coming for pregnant women. Making sure that we've thought about pneumonia, which worldwide is still an incredibly important cause for morbidity and mortality, unfortunately, in young children. And then, of course, thinking about rarer but important respiratory presentations of non-respiratory problems. So cardiac disease, congenital heart problems, as an example. There are some bits in this case that you've described, in particular the long history and the violent coughing bouts, these kind of paroxysms of coughing that are being described in the case would certainly make us worry about pertussis, about whooping cough. Paroxysms of coughing, those kind of really uncontrollable bouts of coughing, are quite typical for whooping cough. Has to be said, you can also get those kind of paroxysms in other viral respiratory presentations, but those paroxysms of coughing are important. The inspiratory whoop that people describe is classic, but not always present. And then, whilst you can have vomiting after coughing with lots of respiratory presentations, it's particularly classic in whooping cough. So I think really thinking about pertussis is important, not least because of the public health considerations which we'll come on to talk about. But just as we mentioned with the previous case, irrespective of the diagnosis, if we're talking about a breathing focus to this case, if you have a child that has got significant increased work of breathing, an oxygen requirement, significant reduction in feeds, for example, if it's an infant with a breathing problem, then those may all be elements of the presentation that might be sufficiently worrying for you to refer the child, irrespective of the diagnosis. In the emergency department, I don't know, take a 12-month-old, for example, with lots of tachypnea, significant work of breathing, crackles and wheezy noises all over the chest, an oxygen requirement and need for respiratory and feed support. I wouldn't say that the diagnosis doesn't matter, but it wouldn't be uncommon for us to think about bronchiolitis and possibly even a wheezy illness that might respond to bronchodilators and possibly pneumonia and the need for chest x-rays and various other bits and pieces purely because the child is sufficiently unwell to cause us that level of concern. We need to look at the child in the whole picture, think about that differential that we've mentioned, but also to stay focused on those slightly rarer but nonetheless really important presentations like, in this case, pertussis.
Okay. So how would you want the primary care clinician to manage Ava?
The interesting and important thing here is that Ava's 6 years of age, which doesn't completely change all of our management. But if whooping cough or pertussis is the thing that we're most worried about, then that is important because whilst there is understandable concern about whooping cough, the truth is that in a 6-year-old child, it is unlikely to be clinically very significant. The really, really important thing about this infection, and I was actually speaking to one of my paediatric infectious disease friends and colleagues recently. He wouldn't want me to quote him as saying this, I shouldn't think, but he basically said, look, whooping cough really is principally a public health problem. I think what he means by that is that there are vulnerable groups that need really serious consideration. So the under ones, for example, and certainly in very small babies, we know that whooping cough can be a very serious and dangerous problem, not least because of things like apnea. In addition, of course, thinking about pregnant women and the risk that pertussis infection poses through pregnancy to the baby that is about to be born. So there are clinically really important groups when we're thinking about pertussis. But overall, in slightly older children and certainly in adults, the treatment, in quotes, for pertussis is not really about symptom control or about symptom management. It's really about preventing outbreaks and preventing the spread of infection so that we can protect those very vulnerable groups like infants, immunocompromised people and pregnant women.
So when we give them clarithromycin as the treatment, we're not really treating them, we're treating the people around them essentially. Is that what you're saying?
That's right. Even amongst some of my medical friends and colleagues, I think there's that sense, finally the GP's given me the antibiotics to treat my whooping cough. And I think it is important that we explain to patients that it's sort of partly what we're doing, but not really. There's actually not much evidence that the antibiotics we're using are going to make your cough go away very quickly. But what we're really trying to do is prevent the spread of that infection.
And it's quite important for them to know that, otherwise they'll just come back in a couple of weeks and say, well, I'm still coughing.
Yeah, absolutely right. If you are not in one of those very vulnerable groups, we're talking about severe outcomes where that's most a risk for children under the age of 2 months and small babies that have not yet been vaccinated, for example, because in infancy, of course, you're relying on quite a lot of maternal immunity whilst you're kind of waiting for your vaccine. And as that wanes and before your vaccine, you are at risk. The really unfortunate cases that I can think of in my career where I've seen babies come to serious harm from whooping cough, those have been very small babies. The harm has come from apnea. And in this case, that's really unlikely in a 6-year-old. I think that's important for us to keep in mind, along with the public health implications. Even the guidance, I think, Ruth, you may be more familiar with this than me, even the guidance for who should be getting antibiotics out in primary care, I think has changed a little bit, particularly with the uptick in infections. If you are less than 14 days with your cough, then treatment with antibiotics, specifically clarithromycin, is indicated. But I think the guidance now, actually, is that after 14 days of coughing, which of course ironically is when many patients will be at their most worried and thinking that treatment really is needed, that the guidance is we shouldn't be treating that. Actually, if you've been coughing for 4 weeks and you think it's whooping cough, that there really is probably not very much to be done there.
Absolutely right with those guidelines. And I think that's really important in the conversations we're having with families, because often families will say, well, can we do the swab first? Can we test for whooping cough? And if it comes back positive, then treat. Well, the truth is, if we wait that long, we've missed the boat for antibiotics anyway. So clinically, if you think there's a reasonable chance it is whooping cough, better to just treat.
Absolutely.
And wait for the results later.
And I think particularly if we're talking about pregnant contacts and young infants, that's again where the real importance lies. There's often a lot of variance in the real world where the local health protection team can be quite helpful. My advice to anyone, including myself actually, is just to remind myself that at the end of the phone is a team who really have got a lot of expertise around treatment and investigation and swabs and so on.
Brilliant. And do you know how effective the pertussis vaccine is at preventing whooping cough? Mum thinks that Ava has had pertussis vaccines in childhood. Does that rule this diagnosis out?
In the same conversation I was having with my infectious disease friend, there's good evidence on the efficacy of the vaccine in pregnant women. And of course, that's where a lot of the drive is coming now to try and reduce infections in small babies. The actual vaccine efficacy as part of the routine immunisation schedule in infancy, I couldn't actually find that much data about that. I think the answer is it is really effective. And certainly this is a disease where there are dynamic peaks and troughs in infection. And my understanding is that the maternal vaccine for pertussis, which I think came in around 2012, that was the response to a big surge in infections at the time. It does sound like there is a lot of concern about falling rates of vaccination in pregnant women for pertussis. There's a particular drop-off in places like London, for example. Encouraging and really advocating for pregnant women to receive their pertussis vaccine, that is almost certainly one of the best things we can do to prevent particularly small babies from getting pertussis.
But then with every subsequent pregnancy, the mother then gets another pertussis vaccine. So can we read between the lines there that perhaps the vaccine isn't that effective for that long?
Yeah, waning immunity, certainly for childhood vaccination, is part of the reason why we've seen some of these upticks. Adam Finn, who many of you will know, who's a very famous professor of paediatric infectious diseases in Bristol, he's done a fantastic TED talk about pertussis infection. It's worth having a look at that because he explains it nicely. Maternal vaccine effectiveness against infant death is estimated to be about 92%. So that's an incredibly effective way of presenting the really nasty outcomes. The problem with the acellular vaccine is that it's very protective but doesn't give very durable immunity. I think that was part of the rationale for bringing in the maternal pertussis vaccine. There certainly has been this sense this year, hasn't there, Ruth, of, God, there's huge numbers of pertussis cases and it's worse than it's ever been. I don't think that's completely true, although there certainly have been a lot of cases. I think what it reflects, and certainly this is what I've been hearing from my colleagues who have real expertise in this area, is that this is probably part of the cyclical nature of these spikes. Now, that doesn't mean that it's not very important, and it doesn't mean that it's not a serious public health concern. But also we should probably contextualise that a bit. Most of the children that you will be seeing in primary care with pertussis are not going to be seriously unwell, but we do need to take it seriously because we want to prevent the spread of infection, which is why treatment in the appropriate groups is important, which is why looking at vulnerable contacts is important, and why, as always, we need to be banging the drum about the importance, not just of routine childhood vaccination, but in this case, the maternal pertussis vaccine as well.
Brilliant, thank you. So I guess we can respond to Mum with that when she's asking about, is there a current outbreak?
Yeah, I think we can say, yes, there is.
Yes.
But it's in some ways not completely out of the ordinary, unfortunately. And I guess we have to choose our language carefully because we don't want to minimise the concern or, for that matter, to underplay the importance, because it is extremely important. But so too are the very real and concrete measures that we have at our disposal to bring these kind of infections, to bring them under control.
Fantastic. So, with Ava, do you think she warrants referral? Is there anything in her presentation that's reassured you or worried you?
Ava's case, which is a child who does not have signs of airway compromise, who does not have signs of significant respiratory distress or the need for oxygen, who's not got circulatory compromise, who's not showing other signs for the need for emergency or hospital intervention or treatment. Actually, a good thing would be to keep Ava away from the hospital, I suspect. What we're not going to be able to do, unfortunately, is take Ava's cough away very quickly, which is quite understandably, said as a parent who's had a child with a nasty cough before, all we really want. And at 4 o'clock in the morning can feel like an extremely torrid thing to be living through. Explaining to Ava's mum that there are no signs of pneumonia or much more serious respiratory infection that are going to compromise Ava, giving good explanation for that, explaining if we think pertussis is the likely diagnosis that it may be reasonable to treat with antibiotics, but again, mostly to reduce the spread of infection. And then to do some testing, both for measles and for pertussis, and for a number of other infections, and particularly since COVID. I think we probably shouldn't overlook or underestimate the importance of what results can mean to parents. And there's a lot of controversy around this because there are financial implications. But for pertussis, for example, I do think parents will take some comfort in knowing that that's what this problem is. This is pertussis. This is how it needs to be managed and how we can prevent the spread of infection. And I think there probably is some validity in that, though the public health benefit is the real one that we're trying to do.
So you're going to be reassuring mum, teaching her about the red flags, giving antibiotics potentially?
Correct. If the child's been coughing for a short duration and we think this is whooping cough.
Yeah, so less than 2 weeks, so we're still within the window.
That's
and
right.
Testing as well. How would we do that?
So my go-to would be contacting the local health protection team. There's probably some variation in primary care, I suspect, and Ruth, you'll be able to tell me this, but certainly the health protection team can send oral fluid kits to the family for home testing. It probably is something we should do more, I think, because I think families, particularly post-COVID, are used to doing some of that. But throat swabs or pernasal swabs for PCR and pernasal swabs for culture, again, are also options. I suspect many primary care services are offering that. I can see you nodding.
Yes. So up to 14 days, I would do swabs.
Yeah.
After 14 days, then you're into the realms of serology.
Absolutely.
And what about schools? Would you have any advice there? Is Ava okay to go back to school? So we haven't got a confirmed case of whooping cough, but there's some suspicion of it from the history. What would you advise mum?
Yeah, that's a good question, Ruth. Do I know the answer to that? I certainly know that if you're treating with antibiotics, which I think would be a totally reasonable thing to do in this case, the advice is that children should be excluded from school until they've had 2 days of the antibiotics. The way I think about that is you've got enough bang for your buck in those first 2 days of taking antimicrobial therapy to prevent the spread to other children. That's certainly what the health protection guidance says. Though I imagine there's lots of variation in practice out there because everyone quite rightly is so paranoid about spreading infection. But I think if you're treating the child with antibiotics, 2 days of treatment and then they can go back to school. I guess a different situation might be if you have not started the child on treatment, but you have sent off some tests. That may be slightly different because you wouldn't want a child with test results pending to be running around a nursery. They were actually positive for whooping cough. That would be more of a concern.
Thank you. So, do you have any key take-home messages or calls to action for primary care clinicians regarding measles, whooping cough, or just identifying the sick child?
Calls to action is a good phrase, Ruth. In some ways, not that much because there are many clinicians in primary care who are doing a fantastic job already. And you would expect an emergency paediatrician to say this, but often nothing is going to be more important than those really objective signs in a really good A to E assessment that help us to identify the sick child. Because if there are serious red flags identified in that airway, breathing, circulation, disability and exposure assessment, then almost irrespective of what's going on, that meets the criteria for a child to be seen in a hospital environment, almost certainly. The flip side of that coin is that if you are seeing a child and actually, despite them looking poorly, they don't have serious signs of an emergency problem through that assessment, then they probably don't need to come to the hospital. It is certainly true that there are many children coming to children's emergency departments who are going straight home again. And that's fine. That's part of what we do. But I think we do want to be doing everything we can, particularly in an NHS that's increasingly pressurised and in the winter months in departments that are not quite big enough like ours, to really be sure that the children going there are the children that need to be going there. And I know your listeners will be doing that already. In the case of really infectious diseases, that adds another level, doesn't it? Children with measles who don't actually need to be in hospital, we're actually potentially doing quite serious harm by sending children with measles to the hospital in that situation. Though if there are valid reasons for sending children there, that's also fine. We just need to think about how we do that. We've discussed a febrile illness with a rash today and a respiratory presentation today, and those are incredibly common presentations. So thinking about the danger signs in a generic way that we've mentioned, thinking about the really important things on the differential for febrile illnesses, so things like pneumonia and sepsis and meningitis. For respiratory illnesses, thinking about things like viral wheeze and asthma and pneumonia. And at any given point in time, I guess acknowledging and having some comfort in the fact that these processes are often dynamic. And we totally understand that a child with a temperature of 39 degrees who's a bit tachycardic because of their fever and looking really poorly at the exact moment they're sitting in front of you as a GP, Ruth, By the time they come to the emergency department, for valid reasons, because you felt they had signs at that time of circulatory failure, for example, they may be running around eating a packet of crisps because their temperatures come down. And we get that. We totally understand that. But I think just being methodical and systematic in our way that we approach the assessment, taking other things into consideration too, totally legitimately, like level of parental concern, time of day matters. There are all sorts of other elements that might come into play, and those are all totally reasonable. For all of us, and it's a sort of mental note to self as well, is not being afraid to talk to our colleagues and to take advice and to sense check. We do that as a consultant group in my department quite nicely, I think. I'm sure right across primary care, GPs and ACPs are doing that as well. And we just need to keep doing that and keep talking to each other, keep listening to the parents, thinking about how we escalate care when there is a level of parental and family concern. And we need to take that really seriously too.
Brilliant, thank you. From this conversation, some of the take-home messages for me are that because a child has measles, that doesn't mean by any stretch of the imagination that they need to go to A&E based on that alone. And even if they've got complications such as lower respiratory tract infections, if they would otherwise be safe to be treated at home, actually it's still okay to do that.
Correct.
That you can still have measles even if you've had the MMR vaccine, or whooping cough if you've had the whooping cough vaccine. So it changes the threshold of how likely it is, but it is still possible, so it doesn't rule it out. That whooping cough is actually most important in infants. They're the ones that we really worry about, those under ones. That's where a lot of the public health measures are focused. And that cyclical nature of whooping cough with having outbreaks every 3 to 5 years. I didn't know that, so that's really interesting.
Yeah, it's important. And the things that you've mentioned, Ruth, of course, are sometimes quite difficult to separate in real time from the patient that's in front of you and the parent that's in front of you. But I think the more context we can give to families, to children as well, and of course to ourselves as healthcare professionals, the better we will become at dealing with what are intrinsically quite difficult problems to navigate sometimes.
And have you got any good resources, either for primary care clinicians or for families?
The one that I think, particularly for measles and whooping cough, that's really worth having a look at would be the Healthier Together website. I'm sure lots of you will be familiar with that. That's got some really nice resources on there, both for parents and for carers. Locally, many of you will be familiar with the Handi app, which is worth a look at as well. But the Healthier Together website, I think, is a particularly nice resource.
And I've set up an Accurix template for my practice with Healthier Together and the Handi app for parents of sick children, with just helping them to distinguish the red flags where they need to seek medical attention. So if your practice doesn't have one, that would certainly be a call to action from me, as set one up.
Yeah, that sounds like good advice, Ruth.
Brilliant. Thank you so much, Dan.
Pleasure.
Do come back and join us next month when we'll be talking about puberty. The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen and interviewees are not liable for any clinical decisions made as a result of this podcast.